Ma intanto ringrazio la dottoressa Maria Ferrara di essere qui e il piacere di conoscerla.
Grazie a voi per l'invito, è un piacere anche mio.
Sì, non vi ho presentato Arianna Montera, la representative del GEDI, Gender Diversity and Inclusion in Medicine, Research and Governance. Non lo so a memoria, ce l'ho scritto. E la dottoressa Maria Ferrara ci ha fatto l'onore appunto di raccontarci il suo lavoro e i suoi anni di studi ehm, sui studi appunto basandosi soprattutto basando questa lecture su gender equality. Ecco Giorgia.
Giorgia.
Buongiorno.
Buongiorno.
Buongiorno. Intanto colgo l'occasione un po' per raccontare anche alla dottoressa Ferrara, magari anche a chi è già online, che l'ospedale San Raffaele ha un team, che è il team appunto, il team JD, che appunto parlava la dottoressa Falletta, e in particolare uno degli obiettivi del nostro Gender Equality Plan è appunto la medicina di genere, quindi ampliare la conoscenza della medicina di genere all'interno dell'ospedale, ma anche fuori. E quindi facciamo una serie di attività. La dottoressa Cinzia Farina coordina il team e in particolare anche tutte le iniziative della medicina di genere. E poi io sono appunto il project manager che mette in pratica tutti i progetti insieme al team. E, e quindi abbiamo una serie di iniziative, in particolare anche grazie ai referenti di medicina di genere, sia in area ricerca e sia in area clinica, che per esempio organizzano questo open lecture, stanno facendo anche dei moduli formativi che adesso sono anche disponibili sulla piattaforma e delle lezioni, alcune appunto aperte come magari potrebbe essere questa e altre per le persone all'interno dell'ospedale. E poi all'interno del nostro Gender Equality Plan in generale ci sono anche altre iniziative non legate alla medicina di genere, ma più su altre tematiche, appunto di parità di genere, che non vuol dire solo uomo e donna, ma appunto come ben sappiamo in modo più ampio, quindi anche per esempio l'età, le differenze di abilità, l'etnia. E altri indicatori di questo genere all'interno dell'ospedale, quindi per le persone che lavorano con noi e quindi sia le carriere, oppure anche stiamo facendo una serie di campagne contro le violenze di genere, il welfare aziendale. E all'interno di questo team, giustamente, ci sono per esempio l'ufficio formazione che è fondamentale per queste formazioni, oppure anche la direzione del personale, direzione sanitaria, insomma, le direzioni sono tutte coinvolte in modo tale di creare dei progetti che siano efficienti al massimo e tocchino diverse tematiche. Direi che è l'una, quindi possiamo iniziare, ditemi voi. Io rimango a disposizione per qualsiasi cosa.
Grazie.
Va bene, grazie mille Arianna. Grazie. E se possiamo cominciare, I'll switch in English. I'll switch to English then. And I'm going to give you a brief introduction of the open lecture of today. So for the people that don't know me, I'm Paola Falletta, and I'm here today as a representative of the gender medicine team of the Experimental Imaging Center at Ospedale San Raffaele. And today it's my great pleasure to introduce Dr. Maria Ferrara, which is honoring us with her open lecture for this cycle of gender medicine lectures. So Dr. Ferrara's clinical and research interests are focused on improving the care of individuals with psychotic disorders. And if I have to briefly summarize her career, I can tell you that she had MD and residency in psychiatry at Università degli Studi di Modena e Reggio Emilia. In 2012, she's been a visiting scholar at the HIV Neurobehavioral Research Program at UCSD. And from 2012 to 2017, she's been a clinical psychiatrist at the mental health department in Modena. And there she led the development of a coordinated service for first episode psychosis in Provincia di Modena. And she created and implemented protocols, organized educational activities for mental health, and she has had many public awareness events. She spent 4 years from 2017 to 2021 as a postdoctoral associate at Yale University, where she joined the research team at the STEP program. Where she helps coordinating the implementation and analysis of the NIH-funded STEP-AD project, which includes Mind Map, which is a campaign that aims to reduce the duration of untreated psychosis. And from 2021 up to now, she is assistant professor at Università di Ferrara at the Institute of Psychiatry, Department of Neuroscience and Rehabilitation. Dr. Ferrara's research interest includes, apart from psychosis, also many other topics such as HIV psychiatry, the metabolic side effects of antipsychotic medications, physical health monitoring in severe mental illnesses, and biomarkers for treatment response in psychosis. During her med school and residency, she has been volunteering as a medical doctor in Kenya and in Benin. And throughout her career, she's always focused on inclusive research with an eye on sex and gender in neuroscience of mental health, as she has fully demonstrated in her prolific published research, which I recommend you to take a look at. So without further ado, I don't want to steal too much time to her, so I give the floor to Dr. Maria Ferrara, and I'm going to introduce her lecture, which is titled Gender Differences in Mental Health Across the Lifespan, Turning Challenges into Opportunities. And please, Maria, thank you.
Thank you, Paola, for this great introduction. And first and foremost, I would like to thank you all for being here and for this kind invitation. And especially, I would like to thank the gender medicine team. We did the JEDI team for embarking in this difficult task of implementing more equal, gender diverse thematic within the workplace and within science, research, and clinical work. So I will start with my presentation. Can you see the slide, hear me right? Because I cannot see you.
Perfect.
So I will start with some definitions, so we are all on the same page. So when I'm talking about sex, I refer to the different biological and physiological characteristics of females and males and intersex persons, such as chromosome, hormones, and reproductive organs. While if I talk about gender, gender is more an umbrella term with more social flavor, meaning that includes norms, behavior, roles that are associated with being a woman or a man or a boy or a girl, and as well as a relationship with each other. The problem is that, problem or not very much problem, is that sometimes gender does not correspond exactly to sex. So during this presentation, when I will use the term women, I refer to individuals of female sex. So today I would like to talk about sex and gender differences in mental disorder. This is a very wide topic, so I will focus on some historical background, epidemiology, risk factors, and pharmacotherapy. And I will conclude with some future direction, some opportunities that we can take to advance the field. So as I said, some historical background. So we know where we started, and we can understand how much sex and our interpretation of sex and gender has influenced even clinical and therapeutic options for patients. So Hippocrates first, then Sigmund Freud later, thought that, for example, hysteria, that is not a case, comes from the Greek word for uterus, could only affect women. In the Middle Ages, the problem was that those women were labeled as witches or crazy, and they were exorcised or even burned alive. And we must wait until the 1980s and the third, so not the first, not the second, but the third edition of the Diagnostic and Statistical Manual of Mental Disorders to have the term hysterical neurosis to be recoded into now is a conversion disorder. And I will give you another example. Dr. Asperger thought that females could not be affected by the autism syndrome that is named after him. And we all know now that this is not the case. And then an example of how sex, behavior, and roles have affected the way doctors have labeled or diagnosed and treated some disorder. So lobotomies in the late 40s were used to treat different conditions. If you don't know what lobotomy is that it's a surgical procedure. They take a needle through the nose and they remove part of the brain. And they were common treatment for insomnia, mood swings, erratic behavior. So I gave you two examples. The first one, top picture, is more pop culture reference. I don't know if you're familiar with the TV series The Boys, but there was one character, Sister Sage, who was a superhero, and she was a superhero because she had a bigger brain, bigger than normal. So she used to perform lobotomies on herself to remove part of the brain. One more sad example is that the eldest sister of the very famous president of the United States, JFK, the eldest sister, Rosemary Kennedy, she was 23 years old when she was treated with lobotomy. So the procedure didn't go very well. She was treated for mood swings, and she became unable to speak and to walk again after that procedure that clearly didn't go well. So when some researchers look at the data about lobotomies in the past, they saw that even if the number of males admitted to the psychiatric hospital at that time was larger than the numbers of females were treated with lobotomy more often than men. Honestly, and there's no much reason for that. So sex, and just to give you some, sex and gender can actually affect different dimensions: epidemiology and clinical presentation, risk factor and vulnerability for certain disorders, and the response to pharmacological treatment, meaning efficacy and side effects. So let's start with the epidemiology. I will talk about psychiatric disorder, but we have to acknowledge that many neurocognitive, neuropsychiatric, neuropsychological conditions, they appear different in men and women, and they are more frequent in one of the two sexes. For example, multiple sclerosis, Alzheimer's disease, meningiomas affect women more frequently than men. By contrast, Parkinson's disease, autism spectrum condition, Tourette syndrome are more prevalent in men. The reason is that sex chromosome complement, X chromosome inactivation, and environmental and epigenetic regulators in sex difference influences the vulnerability for certain disorders. If we take the epidemiology of mental disorders, for example, in the United States, we will see that depression is twice as much more frequent in women compared to men, while alcohol and nicotine dependence is more frequent in men than women. If we take the prevalence in Italy, it's exactly the same. So depression is way more frequent in women compared to men, while alcoholism and substance use disorders are more frequent in men compared to women. So which are the most prevalent psychiatric disorders in men? Alcohol disorder, even if we have to take a close attention to binge drinking in adolescents of female sex, antisocial personality disorder, ADHD, and autism spectrum disorders. While in women, we have depression and anxiety that are very much more frequent, as we saw from the data that I just shown you. Eating disorders are more frequent in female, post-traumatic stress disorders, but also we can see that there is a high prevalence in women of comorbidity of psychiatric disorders. So the co-presence, the co-occurrence of more than one psychiatric disorder, which is really influences the prognosis and it makes it worse in terms of use of resources and the tendency to chronicity, the lower response to treatment. And then we have some disorders that are only present in women: premenstrual syndrome, the premenstrual dysphoric disorder, and the peripartum mental disorders. So I will give you just an example of an epidemiological study that we conducted in the province of Ferrara. As Paola said earlier, my research focuses on psychotic disorders. And I work in a very specialized first intervention service for first episode of psychosis, which is a gold standard treatment for such condition in young people up to the age of 35. So when we look at the data, historical data, 30 years of mental health records from the province of Ferrara, and we split the data at age 35, we can see that the distribution of the incidence of schizophrenia, which is the most severe condition associated with psychosis, we can see that men, they have an earlier onset in their late 20s, early 30s, but when we can see that over age 35, the incidence is more prevalent in women. So we replicated the data that were just published by a larger European study, just to show that age 35 is a not so convenient cutoff for a gold standard treatment for psychotic disorder, because we are actually excluding women from treatment just by their age. To the vulnerability for certain conditions based on risk factors. So sex-related risk factors, which are represented in orange boxes, but as well as gender social factors that are listed in the gray box, influence the phenotypical presentation of mental disorders. And I will focus on risk factors in women because those are quite different. We have psychological risk factors, we have hormonal risk factors, social risk factors. And within risk factors, I decided to put also personal biases in health professionals, because those can become a risk factor for a delayed diagnosis or a delayed treatment for mental condition. So how do men and women react to stressors? Internalized behaviors and dimensions include distress and fear. This is one way to react to stressors in life. And distress includes manifestations such as depression, dysthymia, generalized anxiety, panic, and phobia. And such disorders are more prevalent in women. While externalized behaviors, including substance abuse, antisocial behavior, are more frequent in men, most prevalent in men. But those psychological risk factors, where do they come from? They are interrelated with gender roles and expectation and societal expectation by certain genders. Society expects men to suppress their emotion and feelings. I quoted The Cure with the famous Boys Don't Cry lyric, because they have to hide feelings such as hopelessness, fears, insecurity, because they are usually considered girly feelings. But and rage is way more tolerated when it is expressed by a man compared to women. So little boys and little girls, they internalize those implicit social cues, and they associate, even from a young age, being a man with being assertive, being aggressive, independent, risk-taking. But little girls, they're more, keen and raised with opposite values and expectations, such as being a good caregiver, playing with dolls, taking care of them, and building relationship with other people. So those social cues, they will influence our way to react to stressors later in life. Then hormonal risk factors. It's not by chance that gender differences, they appear, they have their onset after puberty, because especially sexual hormones, they influence the way psychiatric disorders appear in life. They can emerge or relapse during period of life where there is a drastic change in sexual hormones levels. For example, pregnancy or menopause. Why so? Because estradiol, which is one of the main sexual hormones, it has a very powerful antioxidant, anti-dopaminergic, and cholinergic activity, meaning has a neuroprotection role within the brain. And when there is a drop, a drastic drop in its level, it causes those illness that we see in the immediate postpartum or during menopause. And we did a study within the schizophrenia spectrum disorders, and with my collaborator, Dr. Domenicano, and we did saw that, as well as in the European data, we saw that men have their onset during their 20s, while women have their onset in their late 40s, 50s. And this is not a case. This is the age where most women, they will enter the menopause age. And so during the same period, another paper came out by the Iris Sommer group, saying that women with schizophrenia spectrum disorders after menopause, they are a vulnerable group for relapse. So we can have a patient who was diagnosed in their, in her 30s. She was well until she got menopause, and then she had a relapse of psychotic disorder, because this is the hormones. The hormones have a huge role. But why do we care so much about peripartum disorders? Because they can affect not only the woman who's affected, but also future generation. Because babies of women affected by eating disorders, for example, anorexia, have a higher probability of being smaller for gestational age and have a lower weight at birth. And anorexia during pregnancy is associated with prematurity in the baby, with all the problems of premature babies. While on the opposite, binge eating disorders is associated with babies bigger for their age and complication during pregnancy. For example, diabetes during pregnancy, or having to be performed a C-section with all the, the medical complication of that. Postpartum depression in the mother is associated with a higher risk of developing several neuropsychiatric disorders, not immediately, but maybe later on after puberty, like cognitive problems, motor and language disorders, emotion dysregulation, sleep disorders, because they have been exposed to higher than normal level of cortisol, even when they were in their mother's body. And this influenced their later risk of developing psychiatric disorder. Postpartum depression can lead to reduced care for the baby, and infanticide, as we all know if we read the newspapers, especially if there are psychotic symptoms associated with that. And women are more often victims of violence compared to men. All kinds of violence: domestic violence, sexual violence, human trafficking, genital mutilation, child marriage, obstetric violence, and being a victim of violence or abuse is correlated with psychiatric disorder, like all those of the trauma spectrum, including the PTSD, post-traumatic stress disorder, but also anxiety, depression, and psychosis. And if we look at the social role of women, we have to take a closer look, because negative stressful events and chronic difficulties are more prevalent in individuals with lower economic opportunities. And women represent most of the world extreme poor, but they bear 3 times as much as men the productivity, reproductive, and caregiving load. So if we take this with what I said earlier about chronic economic difficulties, you can see that there is a huge potential for triggering depression, anxiety, and other psychiatric conditions. There is job discrimination. There is salary gap between men and women. A woman can be demoted at work after having a baby, or after pregnancies. And I put there a picture of how motherhood affects career in men compared to women. And you can see this huge drop in women that we don't see in men. Also, we need to acknowledge their constant fear for their life in women. And the numbers are there, and we have to take action on that. So, as I said earlier, I decided to include personal biases in professionals. So what are biases? Those are prejudice. Those are what makes us human beings. So they're not bad, but we have to acknowledge that we all have them. Because clinicians can project subconscious thoughts and believe they have a patient, putting at risk the efficacy of a treatment and leading to possible misdiagnosis or a later on diagnosis, delayed diagnosis. So I will give you 2 examples coming from internal medicine field. So given the same pain expressed by a man and a woman, the woman will receive a lower dose of anti-pain analgesic medication. But being a woman is a risk factor for receiving a prescription of a sedative or a psychotropic medication in general. So they wanted to keep us calm. But one more example, very severe, is that a woman accessing acute care for heart attack has a higher risk, a 7-fold higher risk of being discharged from the emergency room without a diagnosis of a heart attack compared to a man. Why so? Because the symptoms are different. Men have the typical symptoms of a chest pain and the arm, and so it is easier to recognize it as a heart attack, myocardial infarction. But women, they have a more flu-like syndrome that can mislead the clinicians if they expect the same symptomatology that a man has. So this, just to give an example. But so you can, given all this background, you will imagine that we have a sex and gender sensitive pharmacotherapy. Well, not so much, because 10 years ago, only 15 of the study included both male and female participants. We have to wait until the 1993 for the US NIH to require the inclusion of females in clinical trials. This means that the majority of our psychotropic medication that were put into the market without being tested on a female body. So this means that given the same dosage, women are at higher risk of being over-medicated because their pharmacodynamic, pharmacokinetic is totally different, and the body composition is different. The proportion of water and other fat is completely different in men compared to women. And so we have drugs that they will more often give side effects to women compared to men. And I will give you just one example because this is one of the most used medication in the psychiatric field, which is the anti-D2 dopamine receptor antipsychotic medication. And the occupation of those receptors by antipsychotics is stronger in women compared to men. Thus, given the same dosage, as I said earlier, women are, they result over-medicated with higher risk of side effects because the side effect most common is the increase in prolactin levels, the prolactin hormone. So in the short term, we will have menstrual problem, sexual dysfunction, ovarian polycystosing, and a milky breast discharge. So just to give you an understanding of what this medication can give, I again give you an example from the TV series The Boys. There was an adult woman that was breastfeeding an adult man, which was kind of cringe. But in my opinion, but is totally biased, could be totally biased, she was taking this medication, so a dopamine sparing agent, and she was able to breastfeed even if she was not, postpartum. In the long term, this higher level of prolactin can cause osteoporosis, but also can increase the risk of breast cancer. This medication is frequently given to people with schizophrenia. And in women with schizophrenia, they attend less frequently than the general population the preventive screening for breast cancer. So if you take these two risk factors together, you will see why a gender-biased approach can influence their quality of life, but also their mortality risk. And so later on, many papers appeared. Some are, mine, but from the Iris Sommer group as well, that we have to consider the sex of the patient when we prescribe psychotropic medication, even if we don't have, up until now, specific guidelines that are sex and gender sensitive. But how can we move the field forward? We have to acknowledge that we all have personal biases. This is not bad, this is great. If we acknowledge we have them, we can overcome them and, study and reflecting on our action during our research or our clinical work. The second point is that we have to promote education on this topic, like I hope today's event. And we have to train professionals about gender and sex difference in all the field of medicine. We have to rethink research methods as well. We have to acknowledge that science as well has had biases. We have to accurately recording, reporting, and analyzing sex and gender difference within our clinical sample, within our sample, research sample. Many journals now, they require you to perform analysis based by sex, even if it's not the target of your research. We have to assess what measure of sex and gender are required to match the research question you have in mind, by bearing in mind that a complication, sex and gender can interact with each other and they change over the course of a life person. As I said earlier, hormones and age take a huge role in changing the levels of hormones and our vulnerability to certain risk factors by sex. And we have to remember that when we do our research. And last point, we have to involve stakeholders such as patients, clinicians, families, because they can give us a different perspective on the consequences of our research, and also some aspect of sex and gender that we might want to consider or to correct our analysis for, in order to understand better such differences. So, which are the take-home messages of this presentation? First, sex and gender are key determinants of mental health and mental health disorders. Sex and gender can actually influence the way professionals diagnose and treat disorder. Remember, heart attack, for example, present differently in men and women. Psychiatric disorder, they present differently in men and women. Subjects of female sex have been historically treated, presented in preclinical and clinical trials, and their problems have been often overlooked. But there are several tools that can help us to improve our understanding of sex differences in neuroscience and in mental health. So I will conclude by thanking the University of Ferrara, my mentor at Yale, and all my residents and students. And I would like to invite you, if you want to come to Ferrara, for a morning dedicated to women's mental health on October 24. You know, Ferrara is a beautiful city. We also have, you know, a wonderful medieval castle. And with this, I thank you for your attention. And last, I would like again to thank the Gender Division Inclusion in Medicine for giving space to mental health, which is often considered the Cinderella of the medical field, but it can actually influences our quality of life and our story and the way professionals treat us. Thank you so much.
Thank you. Thank you very much, Maria, for this beautiful presentation. And I already see a hand raised. Cinzia, if you want to start with a question.
So I also want to thank Professor Ferrara. She gave a great overview on the role of sex and gender in psychiatric disorders. So I have a curiosity, are there studies or initiatives you're aware of about so including people undergoing transition? Because I think that is the best human experimental system to check also the impact of sex hormones, no? In people which have a distinct genetic background.
Thank you, Cynthia, for this question. I am not an expert on sex transition, but there are research on the influence, as you said, of those changes over time, and the way hormones affect behavior as well. Like treating people of female sex with testosterone can have huge side effects, and also there are brain changes according to the different levels of hormones. So I'm sure there are research on this topic, but unfortunately I don't have the data to show.
Many thanks.
So waiting for other questions, I might start with one, which is based on your experience. So if we want to take a bigger picture, apart from sex and gender, there's also the social status that affects, how treatment gets administered and how symptoms could be read by the clinicians. So you have had at least 3 different experiences in your life, the Italian one versus the American one, and then your experience also in Africa. How do you think the social status would affect the relationship between the medical doctor and the person that needs a treatment in your field?
Thank you, Paola. This is a wonderful question. As you said, I had the opportunity. I was lucky to see very different contexts and very different backgrounds and social backgrounds in my career so far. I think that one factor that was everywhere, that was present in each culture that I met so far, is that women, they have a huge, they bear the role of caregiving load. The caregiving role can reduce the possibility for a woman to being able to even express her difficulties. First, sometimes she doesn't have even the time to reflect on her needs because she's overwhelmed with many more urgent needs. A small baby, an older person that she has to take care of in house, and also challenges to have a work and home balance. And this workload can reduce first the possibility that she can even understand that she doesn't feel well. Second, she can't have the economic opportunities to go to a medical visit. This, especially in the US, where the healthcare system is private. Women, if they are not paid enough or they don't have enough money, they cannot afford a doctor's visit. Also, the family around them, and there are many papers about it. One wonderful by Manuela Ferrara in Canada. She interviewed women with psychotic disorders, and she asked those women, she asked them, what prevents you to come to the doctor earlier? And they said that their family members didn't believe them when they were expressing they were not feeling well. They said that they were making drama, they want attention, and this is reported in Canada. Can you imagine in other social system with different background, cultural background? So that's why we include in our specialty program for psychosis also psychoeducational meetings with family members in order to educate them about symptoms, about to recognize early on symptoms, because they can help us, and we can dismantle the stigma that often women have around them when they express their fears and distress.
Thank you.
I hope I answered your question.
Absolutely. There's another hand raised. Is Martina? We cannot hear you, sorry. At least I cannot. No, Martin. If you want to run, she's next door. If you want to run here
Can
and
you hear
ask.
me?
Oh, now, yes.
Okay. Thank you for your talk. I have a general question about which are the main obstacles to achieve a more equal world, can I say? And if you think that there are also the cost of a reassessment of many things, because I mean you talk about medical world, but there are we are in a quite male world, so also cars or temperature in the room are set for according to male. So I have just this question about how much it costs to change the status.
Thank you, Martina, for this question. I think that when you ask how much it costs, well, now my question is already costing a lot to adapt a word, even the pharmacological word that was set for a male body to a women body. So we have to, correct for side effects. We have to, prevent breast cancer because our medication were made for a male body is already costing a lot. If we had specific sex-based guidelines that are sex sensitive, even for a pharmacological treatment, it would cost way less for us for health resources. So I think we have to work towards changing, our work field and even I say within the medicine university course. We have a gender medicine lectures. So we start educating medical students since med school about gender sex differences. So there is med school, there is residency. So for the medical field, I think that education is at the first place. And then I mean, the work that the GDI team is doing is great in the sense that we have to touch all different aspects of life that are all affecting the way we do even only our work. So making, for example, women's schedule more flexible. This is one small adjustment that will make a huge difference in women's life. But we can, I'm only a medical doctor, I'm only a psychiatrist, so I don't know. There's a lot to do, but we can do it.
Thank you.
Thank you. Thank you, Maria. If I have time, and I think I may have time for another question if I don't steal it from anyone else. So you described very well the interconnection between nature and nurture. So genes count, hormones count, the way we have been educated counts a lot. And it's nowadays at least almost impossible to distinguish which is one effect and from the other. I'm thinking about your field when you say, the mental health issues are gender unbalance. You have more schizophrenia, sorry, I cannot pronounce it, early on in male patient, and then there's the overtake of a female. While, for example, depression has the opposite trend, so it's more diagnosed in female. And that's, of course, I think mainly due to the genetics and the really the physiology. I wonder whether the way in which different genders report their pathology could affect somehow how we measure and count and make statistics, because I'm sure that psychosis is very difficult to hide, and I think the numbers are quite reliable in terms of statistics. But if I have to think about depression, which I'm sure men have more difficulties to report, we might be a bit skewed and biased towards thinking that it's actually a disorder prevalent in women. So how do you, with your experience, take into account the self-report of mental illnesses, and do you have strong tools to take it into account that social differences, and how would you improve it? There's room for doing that.
Thank you, Paola. You made a great point about the way we assess and measure symptoms in psychiatry. As you know, in our field, we don't have many biomarkers for mental disorders. So we have to assess patients with structured questionnaires that can help us guiding our diagnosis. And as you said, there are bias there as well, because as the PASSI research showed, depression in women is more frequent, but there are many studies showing that women are more keen to report depressive symptoms, while men will report proxy for symptoms of depression by referring to reduced productivity at work or physical illness. So they will report different thing, but the label of the diagnosis is always depression. So I agree with you that we have to try to adapt our structured tools in order to intercept the disorders based by sex, because even the ability to express emotions is different in men compared to women. Men are often alexithymic, meaning they don't have even a vocabulary for their emotions. So it's different for them to acknowledge, to understand that they are depressed. They don't even know that. So as psychiatrists, and I take a lot of time with the resident to explain this, we have to ask the right questions according to the person we have in front of us. If she's a female, she has her own way to express feelings and emotions and symptoms, and men different as well. And as just one more example, as you said, psychosis is difficult to hide. This is true, but is expressed in a different way in men and women, and at different ages. So when you meet a young boy, 22 years old, with paranoid delusions, I'm certain that the first diagnosis you have in mind for your different diagnosis, differential diagnosis, is psychosis. No doubt about that. But if you meet a 50 years old woman, no record of psychiatric problems, first time visit, and she's saying that she's fearful, that she's worried that her husband is cheating on her, I'm not sure the first diagnosis you have in mind is psychosis, or she's saying that she feels like she's depressed. She will use these terms. This is psychosis as well, but you have to ask the right questions.
Wow, thanks for opening my mind also on that. Thanks a lot. And I think we have reached the end of this beautiful appointment. So I want to thank again Dr. Maria Ferrara and everyone that's attended today, and of course the gender medicine team that gave us the chance to talk about mental illnesses and gender, and open our horizons also on this aspect. Thanks to Maria.
Thank you all of you for listening and giving space to mental health. Thank you.
Great. Bye. Thank you.
Thank you. Bye. Thank you.
Bye.
Thank you. Bye.
Thank you, Maria Ferrara, and for everyone.
Bye.